Thanks for the opportunity to make a few comments about mainly germ cell tumors and a few about sex cord-stromal tumors. Hopefully a little bit of this is new. Again, these are my disclosures. And these are the learning objectives of the talk. I just realized we didn't do the questions on the last one. I don't know if we'll do them all on this one or not, but nevertheless, this is related to learning about the contemporary management of both germ cell tumors and sex cord-stromal tumors, and a little bit about clinical trials. So first, malignant germ cell tumors. I entitled this Coming Full Circle, which in an odd way we are, I think. So, historically, before about 1970, the main source of information about germ cell tumors came from the Armed Forces Institute of Pathology studies, Johns Hopkins, and a few from MD Anderson. And it's interesting to think about, not that long ago, the only available postoperative therapies for these patients were external radiotherapy, radioisotope therapy, mainly radiocolloid gold, and single alkylating agent therapy. And virtually all patients with malignant germ cell tumors who had advanced stage disease died, and only about up to 20% of those who had apparent early stage disease survived. So we've obviously come a long way in the evolution of the treatment. Starting at about 1965, the combination of actinomycin D, 5-FU cyclophosphamide was used with modest success. And then about 1970, Julian Smith here at MD Anderson developed the VAC regimen, vincristine, actinomycin D, cyclophosphamide. By the late 1980s, about the time I was in my fellowship, we converted over to vinblastine, bleomycin, cisplatin. And then by the early 1980s, based on the testicular cancer data and the randomized trial, we converted over to bleomycin etoposide and cisplatin. This is the VAC regimen. It's interesting to note that when I was a fellow and saw my first patient with malignant germ cell tumor, they were being treated at that time for 2 years of chemotherapy. So every month they received the VAC regimen. And that was shortened not that long after to 1 year, and then finally to 6 months of therapy. But we found by the mid-'80s, when we and the GOG and others reviewed their data with VAC, for stage 1, it was pretty successful. Cure rates of 73, 86, 92%. Even 100%, but when we were talking about stage 2, 3, and 4, it wasn't that effective. Only less than all the series, with the exception of one, had cure rates of less than 50% if you had stage 2, 3, or 4 disease. In 1990, we published our first series, 26 patients treated with the BEP regimen. And then a few years later, Steve Williams published the GOG experience with a much larger cohort of 93 patients, completely resected stage 1, 2, and 3, treated with 3 cycles of BEP. And at the time of the report, 91 out of the 93 patients were disease-free. So BEP, certainly by even the mid-'80s, but by the time these reports were out, was our standard and remains our standard therapy. Ovarian dysgerminoma, however, was a little different, because we knew that was the only germ cell tumor that appeared to be very radiosensitive. And so many of these young patients were treated with whole abdominal radiation of some type, pelvic boost, and if they had periaortic nodal disease, which many of them did, they received a boost to the periaortic field as well as mediastinal and supraclavicular areas. So it was pretty extensive radiation, although to any one field it was a relatively low dose. And actually the toxicity associated with these patients in the treatment with radiotherapy was really pretty minimal, amazingly, because they weren't using the doses that were being used in epithelial ovarian cancers. But the main problem, of course, as you know, was infertility. And then by the early and certainly the mid-1980s, we presented our findings, the GOG, similar number of patients, and we found that these tumors were equally sensitive to chemotherapy. And so, for the most part, radiotherapy died in the 1980s, 1990s for this disease, although I'm sure there are still patients who are being selectively treated with radiotherapy, and certainly maybe for recurrence. Interestingly, Steve Williams also was this first author of this paper. It was a GOG study, a cohort of 39 evaluable patients who had stage 1B, 2, or 3 pure dysgerminomas. And these patients were treated with primary surgery followed by 3 cycles of etoposide and carboplatin. So the carboplatin replaced cisplatin. Bleomycin was deleted from this regimen. And in fact, all of the patients were cured with this chemotherapy. And so I would make the case that certainly for metastatic dysgerminoma, you don't really need bleomycin, because I think this is the most sensitive of all the germ cell tumors to chemotherapy. And so with the BEP regimen, though, in general, the cure rates were extremely high for stage 1 and 2, but for stage 3 or 4, only about 75-80% of patients have been cured with this standard therapy. But let's take a closer look at some of the issues related to the contemporary treatment of germ cell tumors. So this is the comprehensive surgical staging that all gynecologic oncologists learn, certainly for epithelial ovarian cancer, and it's been extrapolated to apply to germ cell tumors. I think it's still widely practiced, certainly in the United States. I don't know. Generally, Canadians are much more progressive and open to change than we are in the United States, but I don't know what the standard is there. But in 2004 came a publication from the Children's Oncology group, 131 patients with germ cell tumors. They had much less than comprehensive staging. 97% had no lymph nodes removed. Only 36% had no omental biopsy or omentectomy. 59% had no ovarian biopsy, which we wouldn't do anyway generally. 21% had no cytology. But they found extremely excellent survivals in this group of patients who had less than comprehensive surgical staging or surgery, and so they concluded that survival was unaffected by deviations in the surgical guidelines. So consequently, the standard surgical management of a patient with germ cell tumors by pediatric surgeons in the U.S. is palpation inspection. If they see anything abnormal, they try to remove it. But lacking that, they remove the affected adnexa, and they do peritoneal cytology. They don't do omental biopsy. They don't do omentectomy. That's it. And they feel that that's adequate, and they may well be right. So, at least in the U.S., the current status is that all patients receive postoperative BEP chemotherapy with the exception of stage 1A pure dysgerminoma or stage 1A grade 1 immature teratomas. That's been the dogma, but I think that's changing rapidly and has changed even, because over the past 2 decades there have been several reports of surgery alone for many other types of germ cell tumors, and the benefits are pretty obvious. You spare toxicity in terms of secondary malignancies, premature ovarian failure, the acute effects. So there's a lot of benefit if you don't need to deliver chemotherapy. These are some of the surveillance studies that have been reported as early as '94 in Italy, and then some larger studies later on. You can see the types of germ cell tumors that were included in these studies. And you look at there were relapses in every one of these studies, only 2% in the Cushing study from the Children's Oncology group, but as high as 30% in a large study from UK. So it was a little bit all over the place. But nevertheless, pretty good results. Most of the patients who did relapse were salvaged. About 3 years ago, I became involved with pediatric oncologists from the Children's Oncology group who had formed this international consortium that included pediatric oncologists from UK, and then they added some of the gynecologic oncologists there as well as us, and some urologists and medical oncologists who treat testicular cancer. And we've met biannually for the last few years. This is from a meeting in Cambridge. This is only a small subset of the group. But the leader of that group is Lindsay Frazier, who's a pediatric oncologist at Dana-Farber in Boston. And they had studied a small group of girls with stage 1, and these would be 1A, our FIGO stage 1A, malignant germ cell tumors. It did not include pure dysgerminoma. It did not include pure immature teratoma. So mixed germ cell tumors, yolk sac tumors, embryonal carcinomas, and choriocarcinomas of the ovary. They had 25 patients in this cohort. This was not randomized. All of these patients underwent surgery followed by surveillance. And you can see that 12 of the 25 girls did relapse, some of them fairly shortly after they entered the study, but all of them, with the exception of one, was salvaged with chemotherapy. And so it certainly makes a strong case for surveillance in patients who have stage 1A germ cell tumors. Their staging is a little bit different. So positive cytology and disease limited to the ovary for them is stage 3, and they would treat that patient with chemotherapy. The negative cytology, disease limited to the ovary, stage 1A or 1B, they would treat with surveillance. So this prompted a series of meetings and a long horizon development of clinical trials, international clinical trials for germ cell tumors, not only ovarian, but testicular and extragonadal. And so this is the plan for a low-risk cohort. This study has already been approved by the NCI in the U.S., and it will be activated approximately in September of this year, in which patients who are less than 50 years of age, and this would include patients who have stage 1A germ cell tumors of the ovary, would undergo surgery followed by surveillance, and then chemotherapy with BEP only if they relapse. So that's the low-risk cohort. There will also be an intermediate risk cohort, and for ovary, this would be stage 1C, 2, or 3. And this would be a randomization between the fairly classic BEP regimen, although it's a 3-day regimen instead of a 5-day regimen, versus etoposide, bleomycin, and carboplatin that is replacing cisplatin. You will see that the dose of carboplatin is extremely high, AUC equal 8. I won't belabor the details. That's being changed now to a per meter squared dose of 600 milligrams per meter squared for a variety of reasons. But nevertheless, an interesting randomization that will be for the intermediate risk cohort. That's all going to be one trial, and then there's going to be a separate trial for patients who are in the high-risk cohort. For ovary, that would be stage 4, and that would be a randomization of 4 cycles of BEP, pretty much standard BEP, versus 4 cycles of accelerated BEP, given instead of every 3 weeks, it's being delivered every 2 weeks. And so that's for high-risk patients. So those trials are in development and, again, should all be launched about September of this year. This MAGIC group also published some retrospective review of some prospective clinical trials from the COG and the GOG in UK related to immature teratoma. There were 98 pediatric patients, and there were 81 adult patients in this study that was recently published in Cancer. And what we found was of the 179 patients treated on these clinical trials, of the pediatric patients, 90 of the 98 were treated with surgery alone. The pediatric oncologists do not believe that immature teratoma is sensitive at all to chemotherapy. They don't use it. They many times don't even use it for relapse. They just employ surgery. That was news to us. We didn't realize that. Al Covens is also involved in this as well. And Al, it was equally surprised as I was to hear this a year or two ago. Of the adult patients treated, all were treated with surgery and chemotherapy. When we combined that group, whoops, I lost my slide.
We can still see you there. We're just
Still see them? I can't see them now. Let's see.
okay.
I don't know if I need to sign back in or...
We may need. We can see the slide here and you live. Maybe just if you need to try signing back in, we can definitely.
Yeah, let me sign back in real quick.
Sure, perfect.
Sorry.
No problem.
Oh, wait a minute. Here we go. I'm okay.
Great.
I've got it. So what we found was in the grade 1 patients, nobody relapsed. In the grade 2 patients, only one adult patient relapsed. She had stage 3C disease. But most of the relapses, 19, were in grade 3 patients, and all but 3 of these patients had advanced stage disease. And we also concluded that adjuvant chemotherapy did not seem to decrease the number of relapses in the pediatric cohort, but only, of course, 8 patients had chemotherapy, so I think that was difficult to say. But it is interesting to note that the pediatric oncologists do not employ chemotherapy at all for pure immature teratoma. So in terms of conclusions for germ cell tumors, the current status of management in the U.S. for early stage disease is pretty schizophrenic. In children, they use much less than comprehensive surgical staging. Most patients are treated with surveillance, whereas adults, we're still generally using comprehensive surgical staging of some type and recommending BEP chemotherapy. But that's why we're very interested in participating in this international trial of surveillance for the low-risk cohort. Clearly, further study is needed, and that's why we'll be involved in not only the low-risk cohort study, but also intermediate risk to see if we can lessen toxicity as well as employing more intensive therapy for patients in the high-risk cohort. So a few words about sex cord-stromal tumors, which I do think are among the most enigmatic of the tumors that we treat. But a few principles. I think surgery still plays a key role in the management of sex cord-stromal tumors. I think very uncommonly these tumors involve retroperitoneal nodes. We certainly see patients like this, but it's very uncommon based on studies from our group and Memorial Sloan Kettering and others. Conventional chemotherapy, I think, has only modest activity in this group of tumors at best. Hormonal therapy certainly may be active in granulosa cell tumors. Radiotherapy may have a limited role, particularly for pelvic confined disease. And the discovery of FOXL2 mutations and DICER1 mutations is very interesting and helpful, but it's not yet translated into improved therapeutics for a variety of reasons. This is a kind of this is about surgery, the role of surgery in sex cord-stromal tumors. We know that many of these patients, young patients, can be treated with fertility-sparing surgery. We know that surgery may be helpful in the relapse setting. And in one study from Fotopoulou, published in 2010, she found the most common sites of recurrence were pelvis, liver, and intestine. And she also showed from this table on the right that secondary cytoreductive surgery is considerably more complex and challenging than the primary surgery, since most of these patients have stage 1 disease to begin with. And you can see, if you can read this table, that there are a number of complex procedures, partial pancreatic resections, liver resections, splenectomies, diaphragmatic resections that occur in the salvage setting, but not in the primary setting. But I still think surgery is the cornerstone of treatment for this disease. This is just a placeholder from some of our early studies from the 1990s with PAC and BEP and other combinations. There have been a number of groups, Nicoletta Colombo in Italy, for one, who published extensively on the chemotherapy of this disease. There was a recent report from Memorial Sloan Kettering that I think underscored the fact that these tumors are not that sensitive to chemotherapy, but not totally resistant either. This is just, again, a placeholder as an example of a study showing a variety of hormonal medications may be active and effective in granulosa cell tumors. I don't think they are so much in Sertoli Leydig cell tumors or some of the other even rare subtypes, but granulosa cell tumors particularly they are. This is just a study that Judy Wolf from our group published several years ago on radiotherapy, and again, if it has any role in the treatment of sex cord-stromal tumors or granulosa cell tumors specifically, it's in pelvic confined disease. Jubilee Brown from our group, this is just one of the studies that highlighted the fact that retroperitoneal nodes are involved very infrequently, and so routine lymphadenectomy, we believe, can be omitted from surgical staging. She also published our experience with taxanes in the treatment of sex cord-stromal tumors, and taxanes, we believe, do have some activity. And in fact, this was confirmed in a recent publication a few months ago, a GOG study of paclitaxel in patients for second-line treatment of recurrence of sex cord-stromal tumors, and there was a 29% response rate to paclitaxel alone in this cohort of patients. Bevacizumab was also tested in a study, GOG 251, out of the Rare Tumor Committee of GOG, and we found that there was a 16% response rate. This was bevacizumab alone, without chemotherapy. So I think that has some role in the treatment of these tumors. This is the current randomized phase 2 study in patients with newly diagnosed stage 3 and 4 disease or recurrent chemo-naive disease, all sex cord-stromal tumor types, randomized between BEP for 4 cycles and paclitaxel carboplatin. The study's been open for a few years. It's accrued only 35 of the target 128 patients, so it's very slow accrual, but I think it's an important question to answer, although not an easy study to accrue to because of the randomization. And this is a proposal of a concept from one of your own, Lillian Gian from Toronto, of an anti-androgenic compound, enzalutamide, prostate cancer drug for recurrent, mainly granulosa cell tumors of the ovary. And this is in development. Hopefully we'll be able to activate this study sometime in the near future. But it's just another example of some new drugs that are coming into play in the treatment of these tumors. And as I mentioned, FOXL2, certainly David Huntsman's group in Vancouver has been very active in this area of molecular profiling of rare ovarian cancers and found that almost 100% of granulosa cell tumors and some other lesser frequencies in juvenile granulosa cell tumors and Sertoli Leydig cell tumors have FOXL2 mutations. And then we also know that the Dicer1, either somatic or germline mutations, may occur in girls and young women with Sertoli Leydig cell tumors. These patients may be members of a family with these mutations, and one of the other associations is a rare type of lung cancer in children, pleural pulmonary blastoma. And so if you have a patient with a Sertoli Leydig cell tumor, Dicer1 mutation analysis, I think, is recommended. So conclusions, we've already mentioned malignant germ cell tumors. We need to launch the next generation of clinical trials. I've tried to briefly describe those for you. I think we really need to resolve the issue of surgical staging. I don't think this group of trials is necessarily going to do that, although it will give us some information, because the gynecologic oncologists and the pediatric surgeons are going to stage patients a little bit differently. We also need to resolve this issue of chemotherapy for immature teratoma, and that's difficult to do because you need patients with metastatic disease, with measurable tumor, and actually identifying those patients has not been trivial. And then for ovarian sex cord-stromal tumors, I think it's pretty clear surgery is still the cornerstone of treatment, both for primary treatment as well as treatment of recurrent disease. But there's no question that we need to continue to search for more effective therapy. And I think that concludes my talk. Thank you very much.